Hello, everyone, and welcome to today's webinar from the Peterson Health Technology Institute on assessing virtual solutions for opioid use disorder. My name is Jared Augenstein, and I'm a Senior Managing Director with Manat Health, which provides consultative support to PHTI. I'll be moderating the Q&A during today's webinar. For now, I'm going to pass it to Caroline Pearson, Executive Director of PHTI.
Today, I'm really excited. I'm going to go through our findings quickly, and then we are going to have a panel discussion with two experts in the field, Dr. Allison Lin and Jim Carroll, each of whom bring tremendous expertise to this important topic, and I will share more about their bios later in our discussion. But first, let me just remind you who we are. Hopefully everybody knows by the time you've found your way to our webinar. We at PHTI are conducting independent assessments of digital health solutions. We are excited to release, I think, our 5th report on virtual treatment options for opioid use disorder. And I'll get into a little bit more about what that looks like as we get into the webinar. And let me tell you a little bit more about our process if we advance the slides. We are really attempting, and let's just go forward one slide. We are attempting to really guide purchasing decisions in the digital health space as health plans, health systems, and employers, as well in this case as public health agencies and Medicaid agencies, are thinking about how to better care for people with opioid use disorder. We are really trying to help them understand what the available virtual solutions look like and how to make informed purchasing decisions. And to do that, we are really focused on two core elements of our assessments. That is clinical effectiveness and economic impact. We do that with a systematic literature review and a budget impact model that really seeks to answer these three core questions. Do these solutions work? For whom do they work most effectively? And are they worth it? And so those are the questions that we're going to dive into today. But as part of our process, we try to seek lots of input from stakeholders. We work with a customly recruited set of clinical advisors that help us understand the nuances of these clinical areas and the current treatment approaches. We work directly with patients to understand their journey, what's important to them, and their experience with some of these virtual solutions. And we work directly with the companies that are assessed in our reports, giving them an opportunity to help us understand their products, their solutions, and their clinical and economic evidence. So with that, let's get going. If we go to the next slide, we can see that opioid use disorder is, an important issue in the country, affecting more than 9 million adults in the US, and unfortunately causing about 80,000 deaths from overdose each year. Now, this is in some ways a smaller prevalence condition than some of the others that PHTI has reviewed in the past. But given the serious impacts not only on the people that it affects, but on their families, their employers, and their communities, the disease burden writ large in our society is significant. And we really wanted to make sure that we looked at sort of the role that virtual solutions and health technologies could play in improving treatment options for people with opioid use disorder. Today, the standard of care really relies on medication-based treatment, often using buprenorphine, but also methadone and naltrexone, and then supporting that care with additional services, including therapy and things like peer support, which we'll get into. The opioid use disorder does cause significant health expenditures, as well as other costs, including things like criminal justice. And unfortunately, today, only 1 in 4 people with opioid use disorder are receiving the recommended medication-based treatment, MOUD treatment. Another 30% of people are receiving treatment that doesn't include medications, which we know to be the most effective approach. And then there are many people that not only are not seeking treatment, but do not perceive that they need treatment. And so as we begin to talk about the access picture in this condition, we're going to think a lot about how to reach all of those folks who are not currently attached to medication-based treatment approaches. So let's go to the next slide and talk a little bit about how technology companies and virtual solutions are attempting to change the treatment paradigm for OUD care. So each of the solutions that we look at in this report are centered around MOUD prescribing in one way or another. And they are enabling people to access their medications, often via telehealth visits, virtual prescribing, and really replacing a lot of the traditional in-person care that is associated with buprenorphine-based treatment, and moving that into virtual care. The other thing that many of these solutions are doing is trying to improve patient retention and outcomes by really making that care more comprehensive. So in addition to medications, which are the backbone of treatment, they are offering digital support services that can include things like live therapy delivered online. They can include things like digital CBT-based or other content. They can include peer support programs that occur virtually instead of in person. And then importantly, they include what is called contingency management, which are programs that create rewards for people to continue to stay engaged with their treatment programs. And so combinations of all of these support services get packaged up into these solutions that then in different ways are combined with medication. So if we go to the next slide, what you will see is that we always work to categorize our solutions, and we are focused here on sort of two major approaches in the market. On the left, you see the medication-focused solutions, and that's where the preponderance of companies that we looked at are. And these are solutions that really do include virtual prescribing of MOUD treatments, typically buprenorphine. And then they integrate other support services such as therapy, peer support, and contingency management. And what's very important about these medication-focused solutions is they are really offering sort of comprehensive treatment that someone would engage with in lieu of usual care or sort of a traditional brick and mortar OUD treatment center. So they are, including all of the facets of care in their delivery. On the right, you see the digital wraparound solutions. And these are digital programs that are bundling up in different configurations those support services that we talked about on the last slide, and selling those solutions as a way to enhance other MOUD treatment. So you might have a traditional MOUD provider that's running a clinic, and then they want to ensure that their patients also have access to digital services, support services, and so they might additionally offer one of the wraparound solutions. You also commonly have payers, some employers, and public health providers or agencies that might be contracting to offer these digital wraparound solutions, again, as an enhancement to other medication-based treatment options. So let's go to the next slide. In all of our reports, we spend a significant amount of time thinking carefully about what is the correct treatment or outcomes measures to look at as we're doing our clinical assessments. And we always look at a wide variety of outcomes that are covered in the literature, but we always select a primary outcome with input from not only the literature, but really our clinical advisors. And what is clear in the case of OUD treatment is that retention to medication-based treatment is the primary outcome that is able to predict people's success, to remain in recovery, and is also the thing that is most protective against overdose and other adverse events. So really what we want to see as we're looking at interventions is, can we get folks on average to be retained in care longer, and can we get a greater proportion of patients to stay in care? Of course, there are other important outcomes measures that we reviewed and that are all detailed in the report, including abstinence and relapse rates, symptoms of withdrawal, a variety of questions around engagement and satisfaction. And we always look at measures of health equity in terms of not only how these solutions are being deployed across communities, but also differences in engagement and outcomes for different groups and demographics. This again had a pretty big literature base. We reviewed over 4,000 articles, and the core body of the assessment is really based on 43 unique studies, which is a pretty good set of studies, including randomized controlled trials, a lot of real-world evidence, and company-submitted data. So let's see what we found. On the next slide, you will see that for our primary clinical outcome on retention, we see that patients using virtual solutions had comparable or slightly better rates of retention compared to people in usual care. As we tried to combine all of the retention outcomes across the studies in a weighted average, you see that on average, the addition of virtual OUD solutions, either as an enhancement or substitution for usual care, generally results in about 13 days more longer retention over a 6-month period. And this is a case where, given the very serious risks associated with people falling out of recovery and not being retained in treatment, we hear consistently from clinical advisors that every day matters. And so this is not an area where we have an established MCID for sort of a minimum clinically important difference. However, I think as we all look at the magnitude of the impact of the opioid epidemic in this country, and what we hope for people in terms of being able to get into recovery over a lifetime, we can understand that 13 days is an improvement, but probably not enough to satisfy anyone who's working in this field. The second important question that we looked at in our clinical results was the impact on patient access. So we have long discussed the idea that there are many, many barriers that prevent people from starting treatment. I mentioned on the first slide that not everybody believes that they need help. But we also hear consistently that there are many geographies in this country where there are not good access to treatment providers. So you've got sort of deserts where there's no in-person care available. The frequency with which people need to go to in-person visits can be very disruptive and inconvenient, particularly for folks that are working during their treatment. And the serious stigma associated with opioid use disorder can really make it challenging for people to be willing to go and initiate in-person care. And so I think there's been a great hope in the field that virtual solutions could remove some of those access barriers, making treatment more available regardless of geography, making it more convenient. You can do it in your home or wherever it's, at whatever time it's best for you, and reducing that stigma by increasing the amount of privacy that a patient has during their treatment journey. And so we hoped that in looking at this evidence, we would see a lot of people who had not previously been in treatment moving into treatment through these solutions. Unfortunately, what we find is that there is not evidence that virtual providers are seeing a disproportionate number of people who were not previously in treatment. And that's something that we can talk a little bit more about in the Q&A and with our discussants. But in general, I think that the conclusion is we have more to do to reach out beyond the virtual experience and to really reach new patients and persuade them to initiate care. So of course, the second piece of our results is the economic impact. And this is one where the distinction between the business models matters a lot. So if you remember, the medication-focused solutions I said are an alternative to usual care. They can replace usual care. And in general, they are receiving similar reimbursement to what a traditional MOUD provider would receive, whether that's through fee-for-service or on a negotiated case rate basis. So effectively, it's a direct substitution, and you see slight savings as a result of those treatment, the 13 days longer average retention and treatment. And so you see a very small reduction in health spending associated with the medication-focused solutions. The digital wraparound solutions also improve treatment retention, but because they are sold as an addition to usual care and priced separately from the reimbursement for MOUD treatment, the price of the solutions is greater than the cost savings associated with the clinical improvements. And you see, again, a small increase in spending when those solutions are purchased separately. So if you go to the next slide, this comes together in our stoplight graphics to really show that we do have positive clinical results. The findings really do demonstrate that these solutions are effective and that OUD treatment can translate into a virtual environment well. But we're not seeing the significant jumps in treatment retention or broad expansions of access that we might hope to see. When we layer on the economic impact, the direct substitution of the medication-focused solutions means they don't increase costs, and thus they are an important piece of the treatment options, and we do believe that they should be scaled more broadly. The digital wraparound solutions really need to continue to drive towards clearer sense of how those solutions could be integrated into care without increasing overall spending. So if we go to our last slide before we open it up for Q&A, I want to just talk through a few recommendations. What's next after all of this? Well, at PHTI, we always love evidence. And so we would love to see further development of evidence around specifically which aspects of these support services are delivering the biggest benefits in terms of treatment retention, and also for which populations, so we can figure out how to more closely tailor treatment options to the patients who will benefit the most. We need to continue to focus on expanding access and figuring out how to improve patient acquisition and engagement, really to bring new people into treatment now that we do have convenient, accessible, and private options available virtually. We need to think about ways to better integrate virtual OUD care into the delivery system. We still have many providers that don't think about virtual options when they're talking to patients about their treatment journey. And then we need to find better ways to expand access, including considering the use of opioid settlement funds to fund both treatment and evidence development in the space. And then finally, there are a slew of additional policy recommendations that we put forward around continuing to make virtual care for opioid use disorder more available by finalizing proposed telehealth rules that enable virtual prescribing of buprenorphine, and ensuring that there is flexibility around licensure that enables some of these companies to better scale and staff across state lines. So with that, I will pause and move us on to Q&A. I'll invite Jared back and let's discuss.
Thanks, Caroline. Okay, so I'll start with a clarifying question. You talked about the two different categories of companies that were reviewed. Did PHTI consider solutions that didn't incorporate medications as part of their approach at all?
We did not. And the reason is that the evidence is very clear, particularly in the last 10 or 20 years, that medication-based treatment is the standard of care. It has significantly better outcomes in terms of retention and produces a really huge difference in terms of overall spending for people with opioid use disorder. And so, we are interested in building on the best-in-class treatment in the usual care environment, and then thinking about ways to augment that or enhance that with virtual options.
Got it. Okay, that's helpful. Okay, you talked a bit about the retention improvements, and many of the outcomes that were measured related to retention reported improvements in days and weeks. Is it enough to see economic impact given the relatively modest improvements in retention?
Yeah, so the question reflects like a pretty good understanding of how the budget model works. And so I think it's worth unpacking a little bit. Most of our budget models really have two core inputs. The first is the clinical inputs. So we try to build the models directly off of the clinical benefits that we see in our studies. So if solutions improve health, in most cases, that translates to reduced healthcare spending. And we try to pull that through. Because these solutions have pretty small improvements in retention, the dollar values associated with the healthcare savings from 13 days of retention are relatively small. And that does mean then that the second piece of the budget model, the pricing of the solutions, becomes the most important feature in this particular report. So then you need to look at the solutions and say, how are they being sold? How are they being integrated into care? And where are they priced? And so in this case, the difference between the business models of the two categories, whether they are a substitution for other usual care and effectively are cost neutral from that sense, or whether they are an addition to usual care, really does affect that sort of outcome in terms of the economic impact. And so, that's a correct judgment. Were the wraparound solutions to be sold, for instance, to providers to improve their treatment, but then not separately reimbursed, that would be favorable economically.
Okay.
Or if you saw higher retention rates that did produce more meaningful reductions in health spending, that would also be financially beneficial.
Got it. That's helpful just in understanding the drivers and the budgeting. Okay, so I want to switch gears a little bit. For those of us in the health tech space, there's often this argument that digital solutions, are used to improve access to care. And so it feels like it should be common sense that virtual solutions, in this case, expand access, but you didn't really find that. Can you talk about why?
Yeah, I think this is the most, I guess, surprising and certainly disappointing finding in the report for me. The more I thought about it, the more it made sense, which is we always focus on how to remove barriers to care. And that we have to keep focusing on that, because when you have somebody who is ready to start their recovery and beginning a treatment journey, we don't want to prevent them from doing that because they can't find a provider in their neighborhood. So it is important that we have, low barrier ways to offer treatment, but it's insufficient. It's necessary, but not sufficient. And, the challenge that all digital health solutions, I think, are facing right now is as they deliver, maybe a better, more appealing care model for certain folks, they still have to figure out how to reach those folks, right? Pull them into their experience. And, that is not a virtual answer. That is like real sort of patient acquisition, community engagement. There's been lots of demonstrations about sort of setting up and collaborating with emergency departments. But the question is, like, where do you find someone who is suffering from OUD at the moment when they may be ready to start, or open to starting a treatment journey? And that's a question that the whole field faces, not uniquely to virtual, but it's the other side of the coin from lowering those barriers to access.
Yeah, okay, makes sense. One of the most well-known products sort of in this space was Reset O, which was a product that was launched by Pear Therapeutics, famously received FDA clearance. How did Reset O and their data figure into the assessment?
Yes, and I guess worth saying that Pear Therapeutics went out of business quite with a lot of sort of fanfare and some disappointment from the industry. So I think a couple of things. One, Reset-O as a product has been acquired by Pursue Care, and so though I think the integration of that solution into Pursue Care's total offering is still under development. But the Reset-O data features very prominently in the report and really shapes a lot of our clinical findings. And it speaks to the importance of evidence generation. So, we have never said that all these solutions need to go through FDA approval, but it is striking to see that the one that did go through FDA clearance really led the way in terms of having the most evidence available. So as you dig into the report, you will see a lot of Reset-O evidence showing up. because they have done a lot of work around the impact of contingency management and sort of therapy as an augmentation to medication-based treatment and the way that that affects retention. So those results are really well represented. I will say that they're very consistent with sort of that 13 days at 6 months. Probably the best Resetto study, the largest and highest quality one, similarly found 32 days average improvement in treatment retention at 12 months. So 4 weeks at 12 months, 2 weeks at 6 months. Very consistent performance with our results. And really important, I think, as we hope that we see more evidence from some of the other solutions in the market.
And just to clarify, so that the data was included in the systematic literature review, and then Pursue Care was also included in the evaluation.
Yeah, perfect clarification. Thank you.
Okay. So this will be the last question before we move to the panel discussion. We're getting a bunch of questions on the types of information that you receive from companies. So what types of data do the companies provide, including economic information? What do they share with PHTI, and how do you incorporate that into the assessment?
Yeah, so we first and foremost, we really try to work with the companies to make sure we understand their solution well, right? Websites are only so good, and when you talk to the companies, they really can help you understand sort of what they're doing and how they're engaging and what they think their value proposition is. And then, we invite them to share any and all commercial information, clinical information, economic information that they are willing to do so. A lot of that is in one form or another already publicly available, and so we find it other ways. Occasionally we get things that are sort of pre-publication, and that would be noted. And then, we are very helpfully receiving information directly from them about things like pricing. And in this report, things like their treated patient mix, each of which contributed to both the modeling and the clinical findings.
That's really helpful. Thank you for answering some of the audience questions. I'm going to turn it back to you, Caroline.
Perfect. Well, I am excited for this evolution of our webinar approach because I don't pretend to be the expert on these issues, and I love having guests who can help me out. So let me introduce our panel today. What you will see here is I have two guests joining us. First, Dr. Allison Lin, who served as one of our clinical advisors on this assessment. She is an associate professor in the Department of Psychiatry and a research scientist at the Ann Arbor VA. And her research focuses on developing telehealth interventions for substance use disorders and identifying gaps in addiction care, access, and quality. And then I would also like to welcome Jim Carroll, who serves as the CEO for the Professional Services Council and previously served as the director of the Office of National Drug Control Policy from 2018 to 2021, where he led federal efforts to address the opioid crisis. Thank you both so much for joining me. And let's dive in. So Dr. Lin, let's start with you. You've been an academic leader in OUD research for a while, and we had the benefit of your guidance, but so you understood the report findings. I guess I'd say, what's your reflection having seen the report on, given the report findings, where do we go from here? What's next for OUD treatment and evidence?
That's a billion dollar, it's not $1 million question. That's $1 billion question, or multiple billions of dollars. Actually, I was thinking even more about that just hearing you talk. And I think you pointed out a couple of really key things, Carolyn, which is a few things. One is obviously the opioid and the overdose epidemic has been going on now for more than a decade. But some of this work, especially around virtual solutions, is actually very new. Our team had published a systematic review in 2019, and back then we hardly could find any studies. So, in medicine, usually it takes a little bit of time, and research takes a little bit of time. So that's one thing, but I don't want to just stop there because, just saying that things will take more time doesn't guarantee a solution. The thing I wanted to also focus on is the fact that I think we have addressed some initial issues, which is the fact that these solutions exist, I think is a fantastic thing, right? And that's what took the last 5 years, 10 years to develop these things. But as you pointed out, Carolyn, just because we build it doesn't mean people will come. And that I think is really important because it goes at the heart of what the unique barriers or challenges are for addiction care, opioid and other substance use disorders. we all have to remember that by definition, a substance use disorder is the one medical condition of all medical conditions that is defined by someone's having a hard time making a change despite negative consequences. So by definition, someone with a substance use disorder is going to have a harder time engaging in care, reaching out for care, feeling like they would benefit from care, overcoming the shame, the stigma, of even making that first phone call. And so to me, that means that we need some different ways that care, is built, right? So that it needs to be able to factor these characters in and really be able to engage patients. And I do think that some of the digital solutions do a great job of lowering access barriers, right? So that if someone doesn't have a treatment provider next to them, they can still get in an appointment. But it doesn't mean that a patient or someone with a substance use disorder who at all is considering treatment or very ambivalent, which is the norm, by the way, most of us change our minds 10 times about something, that person has kind of the help or the support to even really think about getting treatment and getting into treatment. And we have some good tools about that. It just hasn't been, I think, fully built out yet.
Wonderful. Thank you. Well, maybe we can come back and talk a little bit more about how to get folks into treatment in a few minutes. But first, I'd love, Jim, to invite you into the conversation. I understand you obviously were a policymaker in this space. I understand you have some family experience potentially, and I'd love to just hear, with all of your many hats, some reactions to the report. What surprised you? What do you feel?
Thank you, Caroline, and thank you to Peterson for inviting me to be on this panel with Allison. It's a great honor. And I think when you look at Peterson, your motto is essentially, let's find out what works. Is it worth it to pursue it? What a wonderful approach that is. It's looking at the data that I think Allison and I both like looking at, is because it actually gives us some direction to some of the less than empirical data that we hear about. But you're right. I started my career as a criminal prosecutor, mainly prosecuting drug cases. You learn pretty quickly that it's a rotating door, and putting someone in jail, certainly, not back in the 90s, was treatment, and you would cycle through them pretty quickly. As you pointed out, I am the father. I am the parent of a child who is in recovery from opioid use disorder, and I am very blessed that we are now in she is in her 8th year of recovery. What I realized pretty quickly is that she is extraordinarily unique. And we did have sufficient funding to make sure that she could spend time both initially in detox and then in long-term treatment. And so I realized that my purpose in life had changed, my focus had changed, and this is why I so desperately wanted to run the Office of National Drug Control Policy. In terms of the report, I guess I'm not surprised. I'm always a bit disappointed. I think those of us who have a lot of hands-on experience always want the silver bullet, right? I wanted you to come out and say, virtual is the absolute, that's all we need. We just need to do this. And we'll never find it, right? Because every patient, every person is unique and individual, and treatment must be tailored to them. In terms of the technology, I remember back, and I guess this was probably, Dr. Lynn, you were talking about 19 first looking at it. In 2017, 2018, I think it was, I saw a demonstration of virtual glasses and putting yourself in virtual reality. And it showed you wearing glasses, walking down a sidewalk, walking up to the door of a treatment facility, walking in, sitting down, all virtually, and trying to get treatment. It was very disorienting. And so I think there are, at the end of the day, some technology that will not replace the human touch, literally and metaphorically. So I think that it's a great access point. It's a great gateway for the meaningful treatment that so many of these amazing companies that are joining us today are providing.
Yeah, that's great. And Jim, oh, I'm sorry, go ahead. Did I interrupt you? Okay.
Yeah.
Maybe sticking with you, Jim, I mentioned the policy. I mentioned the policy angle. My perception, having worked on this a bit before COVID and then revisiting it now, was in some ways, I feel like COVID has actually helped, and that we've seen sort of a removal of some of the barriers around prescribing and some of the DEA rules that made it really hard for treatment providers to scale. So I guess, is that true? Is that also your perception? And, like what else would be top of your mind from a policy perspective about, where we could really improve access here?
Yeah, I mean, first off, we have to address stigma. It's in every part of this disease, not just, for the people who are not directly impacted like me, but for the coworkers, for the neighbors, oh, did you know that so-and-so's child, is battling addiction? But it's also even in responders. There's first responder fatigue. There is emergency department physician fatigue. And so I think, tackling stigma is one of those issues for the outside. The also is something you said, Caroline, a minute ago, that is 95, in the study, 95% of people who did not receive treatment don't feel like they need treatment. I would characterize a little bit as the treatment's not going to help them. It's that they don't, for vast majority, I think it's not just that they don't need treatment, it's that treatment isn't going to work for them. They've lost hope. I think from a policymaker position is you have to take an expansive view. We oversee, or my office oversees about $40 billion. I'm the most conservative person financially, fiscally on this phone call. We're not spending nearly enough money on this issue. And I think taking the long-term view, looking at the data that Peterson is putting out, that so many of the companies here are putting out, you can really see when you look not just at the direct cost, but the indirect cost, doubling the amount of money that the federal government is spending on this is probably a good start. And we can go from there.
Yeah, great. Dr. Lin, you mentioned finding new ways to bring people into treatment, and you heard Jim describe some of the reasons that's so hard. Maybe talk to us a little bit about sort of what's been tried here. Do you see any models that cause you to feel optimistic or that you feel like are worthy of scaling? Like how do we reach people who would benefit from treatment?
Again, a great billion-dollar question. And I'm not implying that I have a solution in mind. I think there are a couple of things to consider, which is, how do we improve upon what we've already built, right? I think that's kind of the phase that we're at currently. And also to acknowledge that there's tremendous variation. There's tons of variation in behavioral health care, and trying to understand across that variation what's associated with better outcomes and worse outcomes is what we're still actively doing. I think a very basic principle that Jim also just alluded to is, we know 95% of people aren't seeking care, right? They don't feel, some of it is that they've really lost hope and not feeling like the care options are going to meet their needs. Some of it is that they don't identify as someone with an opioid use disorder, right? So there's that whole spectrum. And the thing is, we have some good, evidence-based tools to help people who are ambivalent, which is, by the way, again, every one of us, we're ambivalent. And so this idea that we can only help someone when they're ready to stop using is actually not true. So specifically, I'm talking about motivational interviewing approaches to help engage people, to help people resolve kind of discrepancies, to help people elicit their own motivations to move forward. It's not that I know anything about that person. I'm not the expert in that person. That person is the expert in themselves, but identifying ways and goals for themselves. And motivational interviewing is one tool. The other part is, we look a lot at averages, right? And I would actually remind ourselves that although 13 days or the improved retention that we're finding here doesn't seem a whole lot in some respect, within the field of opioid use disorder care research broadly, I honestly cannot name a whole lot of other interventions that improve retention even to that extent. And to Jem's point, like we should be pouring in a lot more resources to understanding this issue because of the broad impacts and stuff. But despite the resources we've poured in to date, honestly, there's not a whole lot of other even more promising solutions. Obviously, we need to do more to enhance kind of the impacts of the ones that we have. But that's just to say that, how do we use these tools? But maybe the problem is that when people need it or when people can benefit from it, how do we help them feel like this is a tool that they might use?
Yeah.
Right? And some of it is a data problem. So how do we identify those who recently dropped out of care, or those who are potentially looking for care but not interested, or those who aren't even looking for care, but who might have symptoms of, untreated opioid use disorder? And that, I think, is a very broad field that we don't know how to do. Some of us are doing some of the research in that area where we do have data, for example, in our health systems and stuff, where it helps us identify people who might need treatment. And so instead of waiting for someone to show up at my door, which, by the way, sometimes takes 5 years before someone has, overcomes all the barriers to come knocking, can we shorten that time frame a little bit? Is one of the questions too.
Yeah, I was just going to say, Allison, you pointed out something directly on point about that care model. Is some people do need that carrot and stick approach that a lot of the alternative diversion courts provide. That when a really understanding judge is sitting on the bench and says to the defendant, you can either go to jail and get crappy treatment, or I can, there are some wonderful treatment facilities that we can send you to in lieu of incarceration. And there, are some early studies that actually show that people who do go to treatment, even when they don't think they need it, actually, do perform at least as well, if not slightly better, than people who seek treatment voluntarily. And so, Dr. Lin, great point.
Jim, that's so interesting. I think sometimes we fall into the habit of thinking about just trying to avoid the criminal justice system, but actually like reframing that as how do we use the criminal justice system as a vehicle for bringing folks into treatment and getting positive outcomes, at the point that people are encountering it.
Yeah, maybe a measure of last resort, but it doesn't have to end, with an arrest.
Yeah.
And I think that's just one example of the different ways that someone's motivation can change. So that's the example, that's the hardest example, actually, where someone might actually not be very motivated at all. But I guess there's the whole spectrum of folks who, let's say on a scale of 0 to 10, they're like, oh, I'm a 4. I may or may not be open to care. That person is usually not going to go through like the 10 steps it takes to get an initial treatment appointment, right? So are there things like maybe even before or regardless if they encounter legal consequences? So are there ways to identify and outreach to that person to help them move along that continuum? I think that's an open.
And are there, obviously the healthcare system maybe plays a role in that to the extent that folks are encountering it. Are there other groups in society or places that are top of mind for you where you say like, this is a place where we could embed outreach more?
Yeah, so I think there's many different things, right? So we know that a lot of people with opioid and other substance use disorders are oftentimes seen in many other settings, right? Their family medicine doc, their mental health treatment. And so some of the work that, folks have been writing about recently is, how do we integrate, OUD and other SUD care in some of these settings? Right? Which traditionally, honestly, are the perfect place potentially because that's where people are being seen, but that's not oftentimes where they're being introduced to effective treatment. So I think there's lots of gaps there. The other thing I wanted to emphasize is, we are really talking about opioid use disorder, but honestly, the vast majority of patients I've ever seen in my life, very few only have opioid use disorder. And in fact, the most common is that they struggle with multiple substance use disorders. And so this expectation that just by treating opioid use disorder, we expect, all of their outcomes to improve, I think is going to be a misconception. And so, and I think there are some questions about this in the Q&A and stuff, but kind of, we know that oftentimes it's the people who have, a stimulant use disorder, an alcohol use disorder co-occurring, and maybe their opioid use disorder treatment it's not meant to address those things, right? So how can we kind of treat that person as a whole person rather than focusing on one treatment? I think those are, again, kind of the next steps to really tackle.
Yeah, I begged people inside the White House to not say the opioid epidemic because I don't think we're limited. I think, sadly, opioids have been around and abuse of them have been around for centuries, but that's not the only drug that is out there. It might be the drug of choice for many, but in addition to people seeking other substances, it's also found in a variety of substances. And so what we're really dealing with is a fundamental issue of healthcare that needs to be addressed, not just the O for opioids.
Totally. And we know Stimulant use disorder is probably double, if not triple more as prevalent. Alcohol use disorder is even multiple times more prevalent, right? So for example, like if someone, and one of the challenges is oftentimes when you deliver opioid use disorder treatment, there are actually treatment programs that really are reticent to address some of the other substances too. And you can imagine that doing so may actually lead to earlier dropout of an MOUD treatment too. So those are kind of the current or next steps that I think are important.
I'm so glad that you raised it, Allison. And I guess so we are getting some questions on why we focused on OUD specifically. So let me answer that, but then let's double click on the limitations of that approach. So we did choose to scope this report just on opioid use disorder. Many of the solutions in this report and the companies are serving a broader set of SUD conditions, and I think that's critically important. Of course, there are some aspects of opioid use disorder and its treatment that are unique, right? The role of the medication-based MOUD treatments is very unique. And in fact, as we got into the literature, you do see that there is pretty wide variation in the efficacy of some of the support services against different conditions. So I'll take contingency management. We certainly have learned that is highly effective for stimulant use disorder, and somewhat effective, but less so, I think, in the opioid use disorder space. So for clarity of our review and making sure that we were honing our clinical evidence tightly, we did focus on it. But I think, to your point, most folks, have multi-substance use disorder at the same time. And that really does speak to the importance of the virtual solutions in being able to address multiple conditions. And I love the point that you made about the fact that may also improve adherence to MOUD care. Anything else to add on the sort of multi-substance use importance and how we tackle that?
I guess to follow up on that, I would say that one of the challenges is, unfortunately, some of the other treatments for the other substance use disorders are even less available to MOUD, specifically contingency management. So it was interesting to see that included as part of the digital solutions, because we talk about availability or MOUD treatment in the about a third of patients, but receipt of CM for people with stimulant or other substance use disorders is probably less than 1 or 2%, right? So there's definitely multiple gaps. And in some of our work, we have definitely shown that probably one of the biggest contributors to low retention or low MOUD treatment is actually among patients who have co-occurring.
Yeah. And I think it's the future, and I think the technology that we're talking about today and the technology of the future is where this is really going to come into play, because the care that the folks on this call are participating in and providing, there's going to be a greater and greater emphasis as we move away maybe from the traditional opioids that we're talking about. It'll be, and so when there's not the MOUD, the MAT, if you will, that is, we know is the gold standard, right? The standard of care, as you talked about at the beginning. When that's not useful for people, which I do think we're heading to, drugs other than an opioid, sadly, that the care, that the folks are providing is going to become even more critical.
Yeah, that's a great point, right? We've seen we have this sort of wave graphic of the evolution of the opioid epidemic, but as fentanyl and other synthetic products and the sort of the patterns of use change, these digital tools, these non-medications may become even more important as part of a treatment paradigm when we don't have medications to rely on. I think that's a great point, Jim. Excuse me. I guess, how do you see the role of virtual providers, in-person, do you think that we should have in-person providers and virtual providers? Do you think we should really be scaling virtual as sort of the model of the future? Like, how do you see the need for a, panoply of options for folks?
Allison, do you want to go first?
I can start. So I can speak to this from some of the research that our team has conducted, where we've interviewed patients about preferences around virtual and in-person solutions. I would say that the bottom line from this work is that everybody's different. which is not shocking, right? And most importantly, people want options. So for example, just 5 years ago, we didn't have any options. We only had in-person care, right? And in fact, people honestly always assumed back then that virtual care was going to be way worse. So the fact that like in this report, the finding is, oh, we're disappointed that, you know, it might have not been way better is kind of a funny contrast to me because literally 5 years ago, you know, when we were talking about doing research on virtual solutions, it's like, oh, that's going to be much worse for patients. So it's kind of funny, the framing of that. But when we talk to patients, you know, what's clear to me is that patients want options. Sometimes patients who say, gosh, I love, you know, virtual options. But then they'll say, you know, Dr. Lynn, I still am going to drive an hour to come see you just because I want to, right? Versus the other person who says, I hate talking to my providers. I don't like doing therapy on the phone or on the Zoom. It never works. I just don't feel connected. But then they say, but if you take that away from me, I can't get any treatment because I'm doing this care while I'm, you know, at work. And I can't drive 2 hours to do weekly therapy otherwise. And so I think that's a very new thing these days. We need to offer patients options, what those options might look like and for who. I think that's an open question. But I think that's the norm now is more of the hybrid.
Yeah. You know, I think one of the things that we're seeing is the disparate treatment across the country and some populations not accessing treatment. And some of it is because they don't have the digital tools, right? We still have 12% of the country that does not have broadband, and that's obviously a barrier. And some of the populations in the country where there are more disadvantages, there's not available treatment facilities or treatment providers. In rural communities, there's not public transportation, and you can't get there. In fact, I was at a very rural treatment facility a couple of years back, and they were saying that one of the problems that they realized is they had to move their parking lot behind the building because everyone knows each other's car in town. And they're like, if I parked out front, everyone would know, oh, Jim's kid must have a problem. I saw his car parked in front of the treatment center. And so they had to pave some empty space behind the building so people could go back there. One of the things where I think, you know, virtual or digital technology is going to continue to play a part, though, is in intervening in those situations that Allison talked about a minute, when people might be most vulnerable to going into treatment, most susceptible to getting it. And, you know, several years ago, in West Virginia really perfected it in Huntington. At least my view, it's Huntington that perfected it. The quick response teams, right, that go within 24 hours to someone who has had an overdose and has been revived to say, we can get you into treatment. What if it wasn't 24 hours? What if someone who has been revived, they're refusing to go to the hospital, and some jurisdictions, they do not have mandated, you know, taking them to an emergency department. What if there was a virtual option, you know, right in the back of the police car, right in the back of the rescue vehicle, where, you know, one of the healthcare providers that are participating in today's call, that they could open up their laptop and speak with someone and say, don't despair, we can get you in treatment. We've got the funding, dear God, please let's get more government funding, and we can get you in right now. And then they enter in where they get that touch. Some researchers call it skin hunger, where people get they just are hungry for that actual physical touch, and they can go get the treatment that they actually want. But the virtual is right there at the scene at the time, instead of as long as 24 hours.
Yeah. Yeah. Another great point that we didn't get to on sort of the importance that, well, we can't get to everything, but, one of the real value propositions is being available quickly, right? And we certainly do see that with these solutions. So I think we're coming to the end. I'm going to ask you each just a big picture question that you can answer, which is, I appreciate, Allison, the framing, the reframing, right? It's our job to push and to constantly be demanding. But it's really important that we recognize that the recognition that these solutions are clinically effective is a huge positive for the field. And while we all wish for ever better retention rates, that, again, this reminder that 13 days matters, and that there's of course, like, averages really do kind of mute the differences, right? In there, you've got patients really benefiting from this care. So I appreciate that positive note, and we'll stick with it. In obviously a very challenging space that you both work in, over the next 5 years, like, where do you think the biggest opportunities are, for positive change in opioid use disorder? Jim, I'll start with you.
I do think it's with technology. I think the barriers or the difficulty, of me feeling that it was a real world to go through wearing goggles and sitting down in an office, to now the use of AI. And I don't think we should discount it. The trade association that I oversee is 400 companies. I went and had some of the staff look. Half of them mention artificial intelligence. These are companies that are for by and large tech companies that are providing solutions to the federal government. A lot of them are in the HHS space. And they're all of them, or at least saying that they use AI, when in fact they might not be creating it, but they feel like they need to say it. I do think 5 years from now, that we'll see the technology getting better and better, being able to pinpoint those most at risk. So employers will also be able to identify employees who might need help. I'm hoping that the technology will be able to teach prevention and do education in an even more meaningful way. I do worry about the technology, especially of social media and its impact on children. But I'm hoping that the tech that your participants today, based on the research you have done, that Dr. Lynn continues to do every day, will produce better and better outcomes, right? We have to be optimistic.
We do. And a quick last positive word from Dr. Lynn.
I think it's what we've been talking about, which is we've gotten so far and we've actually seen overdose rates changing, right, over the last couple of years. But the problem is we can't stop here. And I think today we've outlined some of the next steps, addressing other substance use disorders, addressing the effective treatments that we have for those that people can't access currently. And going back to the fundamental point about stigma, we have come a ways, right? I also do a lot of work in rural communities, and it's honestly astounding in 5 years, people being a little bit more open, right? Less punitive and stuff. But then it's how do we kind of harness that energy and offer options that they can actually use?
Well, thank you both for those optimistic outlooks. I hope that they come to pass. I really appreciate you joining me for this discussion. Thank you to the audience for your engagement and participation today. I am really pleased to see that virtual care does have this promise in OUD, and also I will continue to push for more focus on better outcomes and access. I encourage you to read our full report, which is posted online, and we'll put the link in the chat again. And as a reminder, a recording of today's call will be available soon on our website. Thank you so much for joining us, and have a great day.